Hello, everyone, and welcome to today's webinar, Driving Sustainable Pharmacogenomics Sample Volume. I am Sydney Panilla of LabRoots, and I will be your moderator for today's event. Today's web seminar is presented by LabRoots and brought to you by Thermo Fisher Scientific. To learn more, visit thermofisher.com/pgx education. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. Okay, I would now like to welcome our speaker for today's webinar, Dr. Becky A. Winslow. Dr. Winslow, you may now begin your presentation.
Thank you, Sydney. And thank you, everyone, for joining me today as I present Driving Sustainable Pharmacogenomics Sample Volume. My name is Dr. Becky Winslow, and I am the founder and head consultant for inGENEious RX, a boutique firm specializing in providing fractional medical affairs services for diagnostic companies. Prior to working in medical affairs roles in the diagnostic space, I practiced direct patient care in collaboration with multidisciplinary healthcare professional teams, specifically utilizing diagnostics to manage medication therapy. My expertise lies at the intersection of medical and commercial, and I'm best known in the industry for my work accelerating pharmacogenomics testing to become a standard of care test. Clinical pharmacogenomics is a continuously evolving field, and it has progressed significantly since clinical tests were first developed and clinical implementation began. Testing technology has advanced to become more specialized and also more efficient and cost-effective, making testing more accessible for more people. Researchers have now published robust data supporting the relationships between certain genes and drugs, as well as extensive clinical utility data, such as that's emerged from the Pharmacogenomics Research Network. The Clinical Pharmacogenetics Implementation Consortium has published 27 clinical guidelines translating genetic laboratory test results into actionable prescribing decisions for effective drugs. The Association for Molecular Pathology is publishing consensus standards aimed at standardizing pharmacogenomics across different laboratories and improving patient care. Accrediting bodies for universities that educate healthcare professionals, such as pharmacy schools, now require educators include pharmacogenomics education in their curriculum. Many states, such as California, have legislated state health plans, such as Medi-Cal, reimburse biomarker testing, and several states have legislation pending. And the Right Drug Dose Act, if passed, promises to fund further PGX research. All of these factors have contributed to PGX moving closer to becoming a standard of care, and labs are currently poised to capitalize on the positive momentum pharmacogenomics has built over the last decade. However, for laboratories to help stakeholders realize pharmacogenomics' full clinical potential, they must do more than offer a scientifically sound test. They must successfully navigate the healthcare landscape to consistently find reimbursable samples and at a scale to ensure their financial fluidity and stability, because a failed lab cannot help patients. Even with growing reimbursement and clinical adoption, many organizations struggle to implement effective and scalable sample acquisition strategies. This slide illustrates the laboratory-developed test implementation process. dividing the process into test development and test launch. While challenges in sample acquisition become most apparent in the launch phase, challenges are often rooted in failing to design the right tests in the pre-launch or development phase of the laboratory developed test implementation process. Designing the right test depends on the lab identifying the right payer, right patient, right prescriber, and right time to test. Failing to properly identify these factors sets the lab up for challenges in the test launch phase and financial hardship. To be successful, labs must pay as much attention to detail in the commercialization process as they do when technically processing the test. This webinar's purpose is to provide an evidence-based and focused examination of the PGX sample sourcing landscape, offering commercialization teams a precise, step-by-step market segmentation and penetration strategy to translate clinical promise into operational success. Participants in today's education will learn one strategy by which they may segment and penetrate the healthcare market to drive PGX test sample volume. There are other strategies, but we're going to focus on one that's proven to be successful. I will first define market segmentation and penetration, and then walk you step by step through a case study illustrating how a laboratory may strategically segment and penetrate the market. Market segmentation is a stepwise process entities may perform to divide a broad target market into smaller, more specific groups based on shared characteristics, needs, behaviors, or demographics. The purpose behind segmentation is to help the company understand which groups of customers have similar needs or behaviors, identify high value targets, and allocate resources efficiently by focusing on the most responsive and profitable segments. Market segmentation's benefits include empowering laboratorians to tailor products, services, and marketing strategies and focus on the most responsive and profitable segments. In short, market segmentation is like a game of chess. In chess, you don't win by moving all your pieces in the same direction. You strategize, assess your opponent, and deploy the right piece at the right time to gain advantage. Similarly, in market segmentation, success doesn't come from broadcasting your solution to everyone. It comes from understanding the board or your market and aligning specific products, messaging, and outreach to distinct customer segments, whether it's psychiatrists treating depression or cardiologists managing anticoagulants. Just like you wouldn't open a chess game by rushing your queen out without support, labs shouldn't go to market without a very deliberate plan for where and how PGX testing adds the most value. So strategic sequenced moves win the game and they win markets. Segmenting by payers, covered drug gene pairs, drugs indications, clinical settings, and healthcare providers' prescribing behavior is one proven strategy for segmenting the market. Payers' policies dictate which gene-drug pairs are eligible for reimbursement, directly impacting clinical adoption and testing volumes. As such, they are the cornerstone of any pharmacogenomics market strategy. Understanding these policies is essential for identifying high opportunity targets for test utilization, reimbursement, and clinical integration. Since coverage patterns differ across payers, clinical use cases, and care settings, it's important to segment the market by the drug gene pairs that are covered. Ideally, laboratories should conduct this segmentation before designing their test panels, ensuring that the selected drug gene combinations align with current payer policies. When segmenting in this way, it's also important to consider that payer coverage and reimbursement policies often vary between inpatient and outpatient settings. For a detailed explanation of these differences, refer to the segmentation by setting section of this webinar. Now we're going to look at segmentation by covered gene drug pairs. This slide presents a table ranking payers from the most limited to the most comprehensive coverage. In the outpatient setting, commercial insurers such as Blue Cross and Blue Shield, United Healthcare, Cigna Healthcare, Aetna, and Humana, which the industry refers to collectively as BUCA, conditionally reimburse few drug gene pairs, and they require rigorous documentation, prior authorization, and evidence of clinical utility, necessitating close coordination with providers to ensure compliant ordering. Often, coverage is limited to single gene drug pairs associated with rare diseases such as CYP2D6 and tetrabenazine in Huntington's disease. Coverage policies may also vary between national, regional, and individual plans. Now we're going to look at Medicaid. Medicaid coverage remains inconsistent and state-specific, frequently lacking codified pharmacogenomics policies and sometimes mandating additional steps, such as genetic counseling, both pre- and post-test, which adds complexity to laboratory workflows. The state of California leads other states in passing legislation that requires Medicaid to cover pharmacogenomics testing, and they also fund the budget to pay for the tests. Now on to Medicare. Medicare administrative contractors, also known as MACs, such as Palmetto GBA and Novitas Solutions, manage coverage for the Centers for Medicare and Medicaid Services. Coverage hinges on national coverage determinations and local coverage determinations, which outline the drug gene pairs they deem clinically useful. Reimbursement hinges on the patient meeting their well-defined medical necessity guidelines. These MACs drug gene coverage is second only to cash payers. They cover all drug gene pairs that the United States Food and Drug Administration states the provider needs to evaluate the patient's PGX results to prescribe the drug safely, or the Clinical Pharmacogenetic Implementation Consortium, or CPIC, defines as clinically actionable, which is CPIC level A and B drug gene pairs. In contrast, cash payers, such as patients in direct-to-consumer settings, employers in employer-sponsored wellness programs, accountable care organizations, and research organizations, represent the most flexible reimbursement environments. For laboratories, aligning test offerings with payer expectations is central to long-term sustainability and growth. Now we're going to look at segmenting the market by the drug's indications for use. Once the lab identifies payer reimbursed drug gene pairs, the next step is to determine the diagnoses for which the FDA has approved the drugs and their off-label uses. This analysis prepares the lab to then narrow its market segmentation to the clinical setting where prescribers frequently order the drugs. Examples of indications for use for payer reimbursed gene drug pairs include tricyclic and selective serotonin reuptake inhibitor antidepressants indicated for treating depression, and the genes CYP2D6 and CYP2C19. Another example is statins for treating hyperlipidemia and the SLC01B1 gene. And lastly, clopidogrel for reducing the risk of subsequent thrombotic events in patients with a history of myocardial infarction and recent non-hemorrhagic ischemic stroke, and the gene CYP2C19. So now let's take a look at segmenting the market by clinical settings. After the lab has identified the genes, drugs, and their indications to optimize reimbursable test sample volume, they should then determine in what clinical settings clinicians routinely prescribe the drugs for those intended uses. Clinical settings can include inpatient and outpatient settings. Clinical settings include ambulatory care clinics, hospitals, and long-term care facilities, just to name a few. Targeting business development efforts in the clinical settings with the highest concentration of patients consuming the medications for which payers reimburse the genes sets the lab up to capture more samples. It's very important to note for this strategy that it's very important that payer coverage differences for PGX testing do exist between inpatient and outpatient settings. This is critical to the market stratification process or segmentation process. Labs understanding whether physicians typically and frequently prescribe medications in inpatient or outpatient clinical settings is essential when segmenting the market by clinical setting, as payer reimbursement policies differ accordingly. Reimbursement for PGX testing differs substantially between inpatient and outpatient settings due to variations in billing models, clinical justification, and payer policy frameworks. In inpatient care, non-cash payers typically bundle payments for testing into the hospital's diagnosis-related group payment, or DRG, meaning labs do not directly bill and payers do not reimburse PGX tests separately. As a result, hospitals must absorb the cost of testing unless funded through research or other initiatives. In contrast, PGX tests performed in the outpatient setting fall under a fee-for-service model, allowing laboratories to bill payers directly using CPT codes such as 81225 for CYP2C19 or 81226 for CYP2D6. This distinction renders outpatient PGX testing subject to payers' medical necessity and documentation guidelines, making it more labor-intensive and perhaps financially risky, depending on the lab's risk tolerance. The benefit to the cash model is that the lab is not subject to meeting the non-cash payers' likely narrower gene drug coverage and stricter medical necessity documentation guidelines. Thus, the financial risk is lower in terms of the payer not reimbursing the test. With that said, the economic gain per test may not be as high as that of outpatient care because labs typically enjoy more profit from non-cash payers. For example, anesthesiologists administer volatile anesthetics such as desflurane, halothane, isoflurane, and sevoflurane both in inpatient and outpatient surgical centers. Palmetto GBA, a Medicare administrative contractor, provides coverage for PGX testing of the genes CACNA1S and RYR1 to assess a patient's susceptibility to malignant hyperthermia when the scenario meets specific clinical criteria. In the outpatient surgery setting, if testing is ordered preoperatively by an eligible provider, so for example, an anesthesiologist or a surgeon, the lab is in the Palmetto GBA jurisdiction, Medicare Part B covers the patient, and the test meets medical necessity guidelines, the laboratory may bill Palmetto GBA directly with the appropriate CPT codes, such as 81200 and 81201. In contrast, when anesthesiologists administer the same anesthetics inpatient, PGX testing costs are bundled under the diagnosis-related group payment, or the DRG, and they're not eligible for separate reimbursement under fee-for-service models. In brief, to optimize profits, laboratories seeking to expand PGX adoption must compare the estimated return on their investment in inpatient PGX testing versus outpatient testing. In this example, the inpatient and outpatient settings can both be high-value targets for CACNA1S and RYR1 testing. It just depends on the direct and indirect costs and reimbursements in that lab's particular situation. This table presents examples of outpatient clinical settings in which clinicians frequently prescribe medications for which payers commonly cover the gene when the patient's case meets the payer's medical necessity guidelines. Using the example from a previous slide of the MolDX covered CYP2C19 and CYP2D6 genes and antidepressants for depression, you can see that reimbursable patient samples often exist in behavioral health clinics. Likewise, cardiology practices often include reimbursable SLCO1B1 samples. Please take note that long-term care facilities, primary care practices, and other general practice clinics where clinicians treat multiple diseases for which multiple drugs are indicated are typically reimbursable sample heavy. So let me just say that again. In clinical settings where many types of diseases are treated with multiple types of medications, there's typically a higher volume of reimbursable PGX samples. And to add to that, outpatients, so ambulatory care or non-hospital patients, consuming 4 or more medications are a great target for identifying reimbursable drug gene pairs, no matter their clinical setting. The next step in this market segmentation strategy is to identify healthcare professionals most likely to prescribe PGX testing, as the adoption of pharmacogenomics testing among healthcare professionals is varied. I will now discuss the current landscape of PGX adoption among healthcare professionals, from the most to the least likely to adopt PGX, and I'm going to consolidate them into major provider groups. First of all, nurse practitioners. They have a very high adoption rate due to their prescribing autonomy and strong representation in primary care, geriatrics, and behavioral health. Their protocol-driven practice style and comfort with decision support tools make them proactive adopters of pharmacogenomic testing. Clinical are next. They are leaders in medication therapy management and chronic disease optimization. PGX trained pharmacists possess deep expertise in drug gene interactions and are highly likely to adopt PGX. While most cannot order tests independently, collaborative practice agreements often empower them to do so in coordination with physicians. The next group is physician assistants. Moderate to high adoption exists within this group, and it's driven by team-based care models and firm adherence to clinical decision support tools. Physician assistants are increasingly engaged in pharmacogenomics education and prescribing, particularly in integrated settings such as oncology, behavioral health, and primary care. Their adoption behavior mirrors nurse practitioners when empowered by institutional protocols and payer-aligned workflows. And lastly, but certainly not least, we have physicians, and this would be all specialties. While physicians have the broadest prescribing authority and patient reach, the adoption of PGX varies significantly. Specialists such as psychiatrists and oncologists are more likely to utilize pharmacogenomics testing, while at the same time, generalists may face barriers that are related to time, reimbursement, their knowledge of the product, and a lack of integrated decision support. So, what are the strategic implications of this information that I've just provided you about prescriber behavior? To achieve immediate PGX test uptake, a lab could leverage nurse practitioner driven care and pharmacist programs for cash payers and Medicare, as those payers' gene drug coverage is the most comprehensive. For slower uptake, the lab should prioritize education and support tools to enhance physicians and physician assistants' understanding and adoption of PGX. Okay, now we're transitioning into market penetration. Market penetration refers to the process of entering and expanding within a defined market segment. Successful penetration depends on the company to convert awareness into sample acquisition, orders, or sales, existing customer groups adopting a product or service, and gaining market share and customer loyalty. The purpose behind penetration is to convert awareness into sales. And again, customer adoption and gaining that market share and loyalty. Think of market penetration like advancing your pieces across a chessboard. In chess, it's not enough to just develop your strategy. You have to execute square by square, gaining control of the board, and positioning yourself where it matters most. Market penetration works the same way. You don't win by staying in your corner of the board with a great product. You win by making calculated moves into targeted clinical areas like mental health or cardiology, where PGX has proven value. And just like in chess, every move should have purpose, such as building trust with providers, aligning with payer policies, and embedding PGX into routine clinical workflows. Each small advance increases your influence until you're not just in the market, but you're commanding it. Market penetration tactics include educating healthcare professionals about pharmacogenomics intended uses and clinical application, providing clinical implementation and logistical support, such as seamless test ordering and result retrieval, test reimbursement support, and providing outcomes dashboards illustrating the impact the tests are making on patient care that's specific to the stakeholder viewing the dashboard. Segmentation and penetration in PGX commercialization are like two halves of a winning chess strategy. Segmentation is how you position your pieces, identifying which parts of the board matter most. That means targeting the right specialties, like we've mentioned, psychiatry or cardiology, and then understanding which stakeholders, payers, clinicians, or patients need what kind of value story. But segmentation alone doesn't win the game. Penetration is how you move your pieces with purpose. It's about the execution, getting into those segments, building clinical adoption, earning payer trust, and creating pathways for routine test use. In chess, if you spread your pieces too thin or fail to follow through on your positioning, you stall. And quite frankly, I've seen this happen frequently within the PGX space. So the same goes for labs that segment well, but don't commit to deep, tailored penetration in each target area. The two have to work together. Segment strategically, then penetrate deliberately, square by square and move by move. I will now walk you through a clinical market penetration and segmentation case study. A mid-sized lab in California aims to optimize its reimbursable PGX sample volume. They start by analyzing the payer landscape to identify high-value targets. The lab, located in California, maps the payer landscape by national, regional, and local payers and their covered gene drug payers. Their calculations show they can expect the highest return on their investment into their test with Medicare Part B and cash reimbursements. They design their tests to meet those payers' expectations, optimizing the chances the payers will reimburse the test, including and reporting covered gene drug payers. They have also identified the drug's indications. So now they must identify and target the clinical settings they most likely can convert into high-value PGX customers. They determined that long-term care homes with high Medicare B occupancy are a good target, as patients consuming the covered medications live there, and they often take 4 or more medications. Their research also shows that nurse practitioners commonly staff those clinical settings, and pharmacists often collaborate with them to manage patients' medications. To summarize their market segmentation strategy, the lab's target panel or report is CYP2C19, CYP2D6, and 4 additional genes, and their CPIC A and B drugs, such as escitalopram, pantoprazole, and tramadol. Their target reimbursement is MAC-covered CPTs, or procedural codes, and those would be 81418, 81225, and 81226. Those are aligned with the local coverage determination L38294. Their target clinical setting is long-term cares with greater than 60% Medicare occupancy. And their target patient are those patients consuming 5 or more chronic medications. Their target prescriber is going to be nurse practitioners and embedded medication therapy management pharmacists. Step 2 is to penetrate the market. The goal is to maximize the reimbursable PGX sample volume in the long-term care. The lab can achieve this by stimulating uptake and utilization and building a frictionless infrastructure from test kits to implementation support to make ordering PGX a default behavior. The lab decides to try proven methods such as nurse practitioner focused education campaigns, pre-built ordering workflows, mobile sample integration, clinical support, outcomes dashboards, and medication therapy management triggering of tests. So that is a very short and simple example of how a lab in California could segment the market by payer and also penetrate the market with penetration techniques. This last slide presents suggested key performance indicators the lab can track before and after implementation to determine if their strategies are working. And those KPIs include the monthly pharmacogenomics sample volume, payers' claims acceptance rates, the average reimbursement rate per claim, and the average profit per test. By monitoring these KPIs, the lab will be able to decide how to edit their strategy, or if their strategy is working perfect, so they can just continue to move forward. In conclusion, while clinical PGX testing is currently poised at the height of its existence, for pharmacogenomics laboratories to capitalize on its current favorable position and produce it at a financially sustainable rate, pharmacogenomics laboratories must recognize and overcome historical issues that have led to less successful PGX testing, such as non-optimized market segmentation and penetration. The most clinically valid pharmacogenomics test is not clinically useful if a prescriber doesn't order it and doesn't manage a patient's medications with the results. Labs that succeed in PGX do more than run tests. They design systems for clinical and commercial traction, And the optimal time to segment the market and develop market penetration tactics is in the planning stage in the laboratory developed test implementation process. By segmenting the market based on payer dynamics, clinical context, and prescriber behavior, and by deploying targeted penetration strategies, labs can convert interest into action and scale sustainable testing programs in a very competitive landscape. I appreciate you joining me for this webinar. I'm going to now open the floor to questions.
All right, wonderful. Thank you, Dr. Winslow, for your very informative presentation. We will now move into the Q&A portion of the webinar. So if you have a question that you would like to ask, please do so now. Just type it into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for. Okay, let's go ahead and get started. The first question that we have here says, can pharmacists order pharmacogenomics tests?
Great question. I'm frequently asked this question, and it's a topic of research. I'm actually going to be publishing a paper on this. Yes, pharmacists can order tests when they are within a collaborative prescribing agreement with a physician. So that's the short answer to that question. What's probably very important to the laboratories who are watching this webinar is, do payers reimburse tests that pharmacists order? Payers identify who are providers for reimbursement purposes. So right now, some state Medicaids recognize pharmacists as providers, and they may reimburse a test that a pharmacist orders. But the general rule is that the test would need to be ordered by a recognized provider, such as a physician, for the test to be reimbursed, which is very important in this conversation.
All right, perfect. Thank you. The next one that we have here says, are there resources available in the market for laboratories to see which prescribers have been ordering PGX tests?
There are. I won't name names, but there are databases that exist that will inform a laboratory which prescribers have been ordering the CPT codes for pharmacogenomics testing. They are pay services. I don't know of one that's not that you don't have to pay for. So yes, those resources are available, and those could be a resource for helping to stratify the market when you're trying to identify prescribers for the test.
All right, fantastic. It looks like we have time for one more question here. This one says, what does market access for PGX look like? Is stratifying the market a once and done?
That's a great question. I've been in pharmacogenomics for 12 years, and it's a constant process. And that's good news, because that is indicative of the increase in payer coverage and reimbursement for testing. So as I mentioned previously, we want to segment the market by payers' policies. And so we need to continuously segment the market based on the evolution of payers' policies. So I wish it was a once and done, but no, it's a continuous process. And yeah, the good news is that we're evolving towards more coverage. So.
Awesome. Very good. Well, thank you again, Dr. Winslow, for your time today and for your very important research. We would also like to thank LabRoots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. Before we go, I would like to thank the audience for joining us today and for their very interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webinar can be viewed on demand. LabRoots will alert you when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, everybody, goodbye.